Okay, so nice to meet you, everybody. So I'm talking the coronary artery calcium. And what is important, start with the pattern of the calcium. So when we look into the IVUS into the coronary artery, you have to recognize which is superficial, close to the lumen, or deep side. And deep calcium does not inhibit stent expansion, so differentiation is very important. Number two, this is calcified nodule, slightly different, and this is different outcome. So recognition is important. The surface is irregular, but you see the acoustic shadow, that's definitely calcium. And then when you look into the calcium, we have to evaluate how big. And then typically how we analyze is we put the center of the lumen and we calculate the arc. And sometimes in the pre-PCI IVUS, you see this type of the so-called reverberation. You see the one more layer behind the calcium. So what is meaning? And we analyzed IVUS and OCT long time ago to see any sort way which we can see the thickness of the calcium or predict the calcium thickness by IVUS. That's we plan. When we compare with the OCT, whenever you see such very superficial calcium, and then you see the surface is very smooth, and then you see the reverberation, those type of the calcium is more likely seen when we look into the OCT. But the correlation is not 100%. So I think when we use this information to predict thickness of the calcium, I think you have to be cautious. And this is a different type of the reverberation we see after the rotablator. At the site of the IVUS catheter, you see the round shape of the surface. And this is where the rotablator ablate of the calcium. And then you see the nice reverberation, which is quite similar, which I showed before. And once you see this meaning you ablate this segment. And this is a calcified fracture, also important to recognize. This is before intervention. After the cutting balloon, you see this calcium is completely separate. And sometimes it's difficult to recognize. And the best way to detect, look for the outside. And if you look for the outside, you see the outside structure. That's meaning no longer calcium on the top. In this case, after the cutting balloon, you see the nice calcium fracture both sides. And then after the stent, we see the nice stent expansion. And this is the data which we publish compared to the IVUS and OCT compared to the angiographic calcium appearance. Bottom line, whenever you have the big calcium, you see the calcium by angio. But some number of the cases which showing red, meaning no calcium, even though the IVUS or OCT showing the big calcium. So who they are? And this is a type of the calcium which you couldn't see by angio. You see no calcium in this mild region. And we did the IVUS. And you see the big calcium, this is more than 270. And in this case, we did the OCT together. And what we see is that this calcium is very thin. So what really the angiographic calcium appearance is really looking for the total amount of the volume of the calcium. So even you see the large arc of the calcium, if the thickness is thin, volume is not much, and then we couldn't detect by angio. So to answer that question more systematic way, we analyze, including only the IVUS calcium is more than 180, and then we compare the angiographic visible versus non-visible. And then we see the OCT appearance. If angiographic non-visible, even the IVUS calcium is large, those calcium is always thin, and then not always, most likely thin, doesn't inhibit stent expansion. So I think this is one important message. IVUS cannot detect the thickness of the calcium. However, if you don't see the calcium by angio, you see the big chunk of the calcium by IVUS. Most likely those calcium has to be thin. That doesn't inhibit the stent expansion. And then altogether, we make the calcium score because I really want everybody to pay attention what you look for in terms of the prediction of the calcium fracture and stent expansion in the severe calcium. So those are the factors. We start with angiographic calcium. As I explained, angiographic appearance is important. And if yes, we analyze either big or not, defined as more than 270, like 3 quadrant. And then if so, this is a component of the key of the calcium score. Number one, 360 degree of the calcium. This is very different compared to 330. If you have any segment which don't have the calcium, you can make the good dissection without fracture. So detection of the 300 is very important. Next, big, long calcium. Talking the large amount of the calcium volume, that's important. And the third is calcified nodule, that's really the chunk of the calcium. And also this is a poor outcome. And finally, we including the vessel size less than 3.5. And why? Is because of the pressure and radius correlate with the wall tension. So if you use mid-LED 3.0 versus left domain 4.5, using the same atmosphere like 1618, your wall tension is very different. So when you're treating the small vessel, you have more chance not having the calcium fracture and more chance not having the good stent expansion. So if the small vessel, we keep the 1 score, and if that is more than 2, we recommend to do something like the atherectomy. And there is a very clear interaction between the calcium score and the stent expansion in relation to the atherectomy. So if the calcium score is high, using the atherectomy makes perfect sense, you have the good expansion. But if the calcium score is low, not much sense because you don't see any difference. So prediction is very important to decide when should I use the rotablator. But it is actually difficult to start doing the case. So I think, okay, can you click? Looks like it doesn't work. Okay, I'm sorry, can you click that picture for me? Oh, looks like not working. Okay, anyway, it's okay. So this is, unfortunately, I cannot show, but I can show the still movie soon. So this is a patient who has 84 years old female and moderate age. And angiographically, this is a LED somewhere here, but you see the calcium. That's very significant calcium, right? And then we did the balloon, and then 2 millimeter balloon and 2.5 millimeter balloon, both are rupture. And then we tried to divest, didn't cross. So we consider this is uncrossable as well as non-dilatable region, and we performed the rotor, which is 1.5. This is the IVUS after the rotor. Number one, you see the nice reverberation, which I explained at the site of the IVUS catheter. This indicating we ablated here, also here and here, right? Number two, when you look into the entire segment, it looks like very diffuse disease and everywhere looks calcium, but the calcium is not very homogeneous, meaning here, big calcium, next, not much. Here is big calcium, next, not much. So there is a lot of heterogeneity when you look into the calcium. So in such, for example, the rotor, or like IVL, I heard not available here yet, but IVL is only 12 millimeter. So only like 110 pulse. So if you use where I'm going to shockwave, we really need to know where I'm going to focus. That's important. So this case, I see here corresponding here, that's circumferential, and here corresponding here circumferential, but other place here too, but other place is not. So where is the most significant calcium? Co-register with the IVUS and angio is very important. And how to decide the device? In this case, I have no idea how the vessel size, but go to a little bit distal, I can see the measurement at media to media, that was 3.0. This one, I have no idea how big the artery, but next I see the 3.3. So the vessel taper occur at the site of the side branch. So without side branch, you should consider the vessel doesn't change too much. Therefore, to decide how big the balloon or device to treat this, you should go to the adjacent segment and then decide. In this case, we don't see a lot of difference compared to here and here. We choose a 2.5 high pressure that's indicating the close to 3.0. So we saw that's appropriate size. That's how we decide the device size. And next, okay, okay, it looks like stuck. Oh, okay, sorry. Okay, so next, I think we did the cutting balloon. So I want to go back. Can you go back to before? One before. One more. Thank you. One more. I'm sorry. Okay. So this is a picture after the cutting balloon. So this is a before and this is a after. And I put the exact same place. This is a circumferential calcium. You see the nice fracture, separation of the calcium. And this is same place. I don't see anything behind. Now you see the outside. You see the nice calcium fracture. So that's how you found the calcium fracture. But sometimes there is a confusing things. Like here, this is a wire. And here, this is a side branch. So when you recognize a calcium fracture, we should not confuse. But at the side of the branch, typically, if that is coming from the calcium, that's most likely we can make the fracture from the branch. So that's actually a good indicator of the fracture. So anyway, we make the nice fracture, so we thought we are ready to stent. And then in such, I recommend to analyze the IVUS one more time to decide the balloon or stent size. This case, I measure the distal segment is 3.4, and previously I showed 3.0. So now the vessel larger because we balloon and now it's better flow. And then based on this and the proximal 3.7, so we decide to put the stent from here to here, and the proximal portion is get large using the large stent. This is how you decide the balloon and stent sizing. And put the 3 or 48 millimeter stent, non-compliant balloon distally, and proximal using the different size of the balloon because this is very tapered already, so we're using the different balloon. And this is a final result. And this is a small artery distal segment, minimum stent area 4.6 compared to the normal side, which is more than distal reference. I'm very happy. And this segment, shape doesn't matter. So really, because of the calcium, we cannot change the shape. So as long as good stent area, that's fine. So we are very happy. This is how you decide. I'm done. Okay, this is a final. Okay, it's interesting that this movie was worked. Okay, good. Okay, this is a different picture, and this is a different case. You see the small lesion, and this is how it looks like. Okay, it's a different compared to the other picture. I said small calcium doesn't matter, but this case compared to the distal, the lesion was smaller. That's negative remodeling. So whenever you have the negative remodeling, even the small calcium, it's worse. So we decided to do the additional treatment because otherwise this is going to be underexpanded. In this case, we did the orbitally. You see that the site of the chunk of the calcium, you see the nice reverberation. This is a new reverberation. So you see at the site of the IVUS, round shape, now good reverberation. That's indicating we ablate here. After stent, this calcium was separate. That's making the nice calcium fracture and a good stent expansion. Done. And this is a very special scenario. So we say if the calcium is less than 180 degrees, it's not important. And in this cohort, we analyze 1,000 cases. All cases, calcium is less than 180. Stent under expansion only 5%, so it's not many. But when happen is this type of cases. When the lesion having the negative remodeling together with the eccentric calcium, and interestingly in this study, we see the mid-LAD lesion having the more likely under expansion. If all together, there is a significant number, it's going to be under expanded. So this is a very special scenario. Small calcium is okay, but together with the negative remodeling, be careful. This is a very different type of the calcium. The patient was old and thank you. Yes. I'm going to finish. Don't worry. Okay, so this patient was CKD, and then we treated using the rod and stent, and 2 months later, what's happening is actually this is thrombus. And this case, it's quite interesting. This is after the stent, and then 2 months later, you see the calcified nodule is reprotruding through the stent. This is really the phenomenon the pathologists tell us. Calcified nodule is an accumulation of small calcium fragments. So when you look into the pathology, this pink, tiny pink, is all individual is a calcium fragment. So they are reprotrusion on the stent that's happen clinically. So this is from Japan. They compared with without calcium, their poor outcome. And when this stenosis occur, instant calcium, patient who had the calcified nodule, 82% was reprotrusion of the calcified nodule. So this is very important to recognize. Okay, that's 1 minute. So if I'm talking about IBAS, this is we published OCT study to differentiate the calcium in the instant calcium as well as the peristent calcium. So when we look into the instant stenosis lesion, and in peristent calcium appear early, like 3 years, but inner stent calcium appear about 5 years later. And why this is important in IBAS? Because we couldn't differentiate the thickness of the calcium, but at least you can say this is neoarterial calcium because I don't see any stent behind. But in such, you have to look into the adjacent frame, and most of the time, this is not homogeneous. You should see some non-calcium segment. That's meaning this calcium is not very thick. And we are going to publish this data. This is all neoarterial calcium by IBAS. And what is important by IBAS? Not only the inside, but also the reference segment calcium, because native calcium and instant calcium is correlated a lot. If you have the big calcium in the reference, you have the big calcium behind the stent, which is very difficult to treat. So if you don't have a lot of calcium in the reference, you are unlikely having the big calcium in the stent. So looking at the reference is very important, and also like the diameter is important, and also the length is important. Okay? I'm done. So I think to summarize, don't forget to look for the angio carefully. Angio appearance is actually very important and correlate with the amount of the calcium. So when we predict calcium fracture or stent expansion, what is important is look for the total volume, not just arc and also length. IBAS cannot see the thickness, but you should be able to predict using the many different ways. And finally, I show the neoarterial calcium, and amount of the calcium inside length is also important, but IBAS cannot see the thickness and look for the outside. And if not much calcium, you should expect the inside behind the stent is not much calcium. That's actually very helpful. Thank you so much.